I'm now in Israel, and I am executive chairman of the Occiton Medical. Occiton developed and today commercialized the world's first FDA-cleared pulse oximetry monitor at risk. FDA-cleared, and today only 3 such devices FDA-cleared we have in the market. And I have PhD in physics from Weizmann Institute of Science in Israel, and for the last 20 years I spent in medical and healthcare area, like engineer, executive, and serial entrepreneur. Also, I am an official mentor at Israel Expert of Institute, and recently, most of my time I started to dedicate to help young entrepreneurs to grow their business. So I'm working with several accelerators in US and Europe, and make motivational mentoring of young entrepreneurs, and they're happy about it. So I'm very glad for invitation to participate in this webinar, and I expect very, very interesting conversation here.
Thank you very much for that, Leon. I'm now going to bring in Mary Akangbi. Mary, can you say a little bit about yourself, your background, and your interest in telehealth and telemedicine?
Oh, hi, my name is Mary Akongbe. I'm a specialist practitioner in minimally invasive surgery and robotics in the NHS. I'm also the founder, president of Zenith Global Health. The idea behind that is to create a platform for shared learning in every area: management, capacity building, training, mentoring, globally, so that together with a unified voice, we can do what we plan to do for our patients, deliver optimum care. In our training and mentoring, we usually support healthcare professionals to upskill and to upskill, especially in the area of telemedicine and health technology, to find synergy within industry, government, private, and also to support them to find how their products, as you may, created for the patient's health can work well from top to bottom, not just for certain percentage, both here in the UK and especially across low, medium income countries. Yeah, so that's what we do. That's my passion. Thank you. Thank you for having me.
Thank you very much for joining us, Mary. Last at the moment, but not least, is Douglas Samandishi. Douglas, tell us about yourself.
Hello, guys. Thank you very much, David, for the invite. I've looked very much forward to this conversation. My name is Douglas Samandishi. I'm a clinical consultant for Alcidion, as well as a clinical safety officer. My passion is all about patient empowerment. I've got engineering background before entering the healthcare sector, and I was part of the national program for IT. So digital change, transformation is something I'm really keen to speak about, and particularly as it pertains to transforming human lives. I like to humanize the whole process of digital tech. So if we work from the perspective of the patient back into the hospital, I'm ultimately trying to liberate patients from anything associated with having to come into a hospital so that they can live their lives to their fullest potential. So I'm looking forward to hearing from the other panel guests as well. So thank you very much for having me.
That's a pleasure, Douglas, and thank you very much for joining us this afternoon. We're now going to start to look at telemedicine, telehealth strategies in different countries. As I mentioned, we have some panelists with some great international experience, and what I'd like to hear from them is their thoughts on how telemedicine and telehealth practices are being deployed in their specific country. What are the good things about these practices, and what are the problems? As Douglas mentioned, it's one of my passions too, that we have a human touch. Is there a danger that some of the telemedicine and telehealth strategies are taking that human touch away from us? So I'm first of all going to bring in Brian. Brian Arkwright is in the USA. Brian, tell us about telemedicine and telehealth in the USA from your perspective. What's good about it, and what are the kind of problems that people are having to deal with?
Yeah, great question. I live in Charlotte, North Carolina. I grew up in Ohio, so kind of grew up in the Midwest, been working in the Southeast, but advise hospitals and healthcare organizations across the country and across the world. In the US, we just seen explosive growth from COVID. I think that was probably the most exciting thing that's happened with telehealth. You know, if you're in the circles, everybody would say, you know, next year's the year it's going to really grow. I don't think anybody had any clue that it was going to grow as fast and as much of that it did when COVID hit. So really nice to have telehealth kind of help win the day or help solve some of the problems that were going on around the globe. But you know, innovation, growth, and research have been going really well for telehealth in the US. We're seeing a lot of really great best practices being shared. There's a lot of health systems, you know, really investing in telehealth that weren't in the past. So we're seeing a lot of scale, a lot of growth. And then what it's done for mental health, the access, I think, is fantastic. I think those are things that are working well and going well. The problem, you know, we wanted to kind of list, you know, what's going well and a problem as well. I think, you know, we'll be kind of finalizing some policy and legislation to continue to encourage the adoption and management and oversight of telehealth, ensuring that it yields the same quality care or better than in-person care. I think that's something everybody strives for, is to maintain high quality with telehealth. And that's something that is developing. I think health systems they had to rush and set up a lot of things very quickly during COVID. For the ones that weren't already doing telehealth, I'd say maybe 30 to 50% of the market was doing it. The others had to kind of start from scratch in some situations. So I think documentation around quality, you know, overall analytics, and really figuring out that cost model or the, you know, value of investment versus maybe the traditional return on investment that you see with telehealth. It yields incredible benefits, not just quality, access, cost of care. It can really bring in a lot of positives. So kind of working, I think that's something that the US and everywhere kind of will continue to work through. So, but yeah, I'll leave it with that, and can add, and equity. I think health equity is, you know, there was some things with CMS, which is our regulating body, one of them, that opened up some light to telehealth, did not necessarily encourage equitable access, or we didn't see equitable access across the country. So that's something that people are now can razor in on and use telehealth to hopefully address equitable care and improve equitable care.
One of the things that we're seeing in the UK, not in recent days, but certainly before, a lot of pressure to go back to face-to-face consultations, particularly in the press, saying, you know, you can't beat seeing a doctor face-to-face, and they really ought to be forced to see you face-to-face if that's what you need. Are you seeing that in the USA?
There's, you know, I think numbers hit like 80, 90%, I mean, even 100% of some practices had shifted to virtual. So now we're seeing that drop down, you know, significantly. But prior to the COVID, there was like 0.05% of all healthcare was done virtually. Now, I think everybody's kind of planning on, or what I'm seeing in a lot of health systems is right around that 20%. Give or take a few percentage points. I think if you're in the kind of 15 to 25%, that's a pretty healthy range to be virtual. I think other systems have said 50% plus. It's kind of been all over the place, but I think a healthy number is 15 to 25%. And it's really striving for, you know, not wholesale replacing telehealth with in-person, but finding those visits that work well for telehealth, and that works well for the patient and the provider as well. So, you know, not forcing it, but taking kind of a hybrid approach, saying, all right, telehealth is great for this type of visit, but let's kind of lay off this type of visit. We really need them to come in. And so once health systems, practices, organizations start to kind of, you know, go down into the details, I think they'll satisfy a lot of patients, they'll satisfy a lot of providers, and they'll get some really great kind of efficiencies and quality of care. I think that you'll see kind of all these once you start to do some of the detail work.
Okay, thanks for that, Brian. I'm now going to go on to Leon and ask for his experiences in Israel. You have experiences to share, of course, in the USA as well. But what's happening in Israel with telehealth? It always strikes me that they're very technologically advanced in Israel. How's it working in practice?
Yeah, historically, Israel is a startup nation. And we do a lot of startups, a lot of innovations. But it's a small country, so most of innovation we do for the expert, and then this innovation get back to Israel. So about adoption of this innovation here, we have some lack of this adoption, and it takes time. And I think today still people prefer face-to-face meeting. But we have very well developed digital part of healthcare, digital part of medicine, electronic health records. We have all data in one depository. So from this point of view, we're very well developed. But telehealth itself, I think we have to work a lot on adaptation of such technology and change people's mind about it. So there is a big lag between Israel and United States from point of view of
this. Maybe I can ask you this question. I'll bring it up again because we've had one question from Liz of Medication Support. How does US telehealth cope with function issues across wide distances, especially if the operating systems are across state? Are there any issues with distance? You say in the USA?
In the USA, there is distance. In Israel, there is no such thing like distance.
No, maybe I should just direct that question then to
Right.
Brian and see Brian, have you got any comments about that question?
Yeah, it's a great question. Especially when you have, rural, we call it rural, kind of like the farmlands, and there is quite a bit of distance, and the bandwidth, the internet connectivity is not always suitable to do video. And so that was another kind of thing that came out of COVID is more audio types of visits and really, detailing out, all right, these types of visits are good for audio or can be done audio. And then others maybe are video only or recommended video only. So yeah, the distance can cause issue. But that's a great way to kind of pipe in, a lot of these specialists, neurologists, psychiatrists, who don't operate in every county, in a particular state. We call them dry clinical deserts, or just areas that have terrible access, health provider shortage areas, we call them. So that's where we can look to telehealth to solve that, as long as there's good, internet and bandwidth connection.
Good connectivity. Okay, yeah. Thank you for that, Brian. Now I'm going to go over to Douglas. Douglas, the UK. What's your take on how telemedicine, telehealth has evolved in the UK? What positives can we take from it? What kind of problems are we likely to see?
Okay, I think it was teed up quite nicely in terms of giving the background, even though it was from the US perspective, but there's a lot of synergies that we can extrapolate for the UK when it comes to telehealth. The first thing I want to say is telehealth needs a rebranding exercise, should I say, because it almost needs to be rebooted, and COVID was a key catalyst for that rebooting. But it's just the name remained telehealth, and television does not even, it's not what we're talking about here. It's got a naming and branding issue along with it. But essentially, when you talk about telehealth in the UK, traditionally it was used to manage long-term conditions. And you will give a patient in the home access to devices to monitor blood pressure and other vital signs, as it were. And that had a varying degree of success based upon having access to these devices. So what we've seen, particularly over COVID, during that period, these devices for physical health monitoring have become cheaper and cheaper and cheaper. Access to digital has becoming cheaper and cheaper and cheaper. So there's no wonder, and obviously COVID meant that you got to have more virtual consultations. So where there was a dip in low uptake, or the uptake was only based upon a post-cultural lottery, those in more affluent areas, the NHS right now, as it stands, is focusing on two key directives. One, we're talking about the green agenda. How can we have a more sustainable healthcare service? That means we don't want people traveling back and forth who can be cared for in their own environment, okay? On top of that, we've got the health inequalities approach, whereby we want to make sure everybody has equal access to services. And for me, what's emerging is the emergence of choice. That's what's happened. I'm not too concerned too much about what how many people choose a particular type of care pathway to engage with. It's more to do with what fits the demographic or individual's own needs. And that's where I'm seeing it. So a lot of people who want to have the face-to-face consultation, they should have that choice. And certainly that in that comes traveling, in that comes allocation of resources, time, and all of these other factors, when it could very well be we have more better, standardized, more effective, more efficient ways of monitoring somebody's health so that they can be liberated from health. So there's an element where I see, particularly in generations that are used to seeing the GP. But if you speak to a lot of younger, say, students who are studying away from home, a lot of them tend, from my experience as a clinician, tend to prefer a remote consultation. So it's not a one size fits all, but certainly choice is a key driver in what we are trying to get to. But I would say lastly is, as somebody that's keen on innovation and transformation, this health service as it's morphing into is something that we never really fathomed before. I've not seen any full business case that really clearly articulated the way health is going right now with virtual consultations, because there's new capabilities, there's new teams, and new roles being defined. As a nurse, when I see my patients in the community, if they already track their health trends and what their health is doing, my role changes. Instead of somebody that's directing treatment, I'm more signposting them for more and more effective types of treatment, opposed to directly intervening in certain cases. So there's the educational piece, there is the zero carbon, the green agenda, and also health inequalities that are the undercurrents of where I see telehealth going into the future.
That's a great answer. And you really trumped one of my questions, because as a person of the a baby boomer, shall I say, one of the things that I experienced growing up is that we had our own GP and the family doctor. Families had a personal relationship with that doctor. And that's one of the concerns, certainly for people of my generation, that they feel that they've lost something. Maybe through telehealth, they don't have that personal connection with one individual who knows all of their history. But we'll be able to talk about that in a bit more detail a little bit later. I now want to move on to Mary. And of course, Mary, in Africa has its own problems and situations with demographic situations, distances, etc. What's your experience of telemedicine and telehealth in Africa?
Yeah, thank you very much, David. The problem is actually similar, but the solution is different. For instance, in our network, when we have the yearly summits and the award ceremony and people then make submissions, we've been doing that in the UK for 7 years. We started 2 years ago going across Africa. And what we found going across Africa is that there's more and more submissions around innovation, health technology, telehealth. Then we begin to ask the question, how relevant this is and whether they are fit for purpose. And also because of the high turnout, sometimes, they play catch up with these things. And also there are some situations, for instance, we're talking about cost. We're talking about access and accessibility. Yes, it's great, but when we think about the people who are in the really remote areas, how do we reach them and how do they reach the product? For instance, non-communicable diseases is very, last year we focused on diabetes and cancer, and the statistics are grim. There are wearables and different things that people can use to monitor their health, but access and affordability then comes into place. So for anyone who is operating in this market to be able to actually reach a good percentage of the people to make it relevant to the countries is really a struggle. And even when they talk about the public-private partnership, again, there's a limit to that. The cost comes into play. But the good thing about that is that it makes people now start asking questions. What can we do? Because telehealth is here to stay. So it's not something we can say it's not for us. It's for us. It's for everybody. So questions are now being asked. What can we do? How can we do this? And how can we make it relevant and, useful for the people? So now we have, people in our network who are now powering their stations in the remote area through solar energy. So for LMICs, that is great because now we are creating opportunity for that particular industry to merge with healthcare. And it's not uncommon to be that the people behind this have engineering background. So I think over time, they'll be able to work together to make it work. Because the other problem is the human touch, like we said at the beginning. Again, early this year, we were supporting a company in America to facilitate trials in Nigeria. And when we were having the meeting with the federal hospitals, we were talking about how do we then, the data collection and then patient follow-up, because it's on surgical site infection. We have to see, to make sure on day 7, day 10, to make sure. Then, okay, so we came up with the solution that we use telehealth. Yes, it's good because it will ensure compliance. They will show up to show us they won't. They don't have to travel to the hospital. But we have to rely on their end having good lighting, and then the connectivity, and also even, with the hospitals, we have to rely also on energy. So there are different things that comes to play when it comes to Africa, but also the enlightenment is bringing, is challenging the people, especially the governments, to start asking questions and now to start working with everybody, healthcare professionals, innovators, which is, what we all like to see, really.
So the one thing I remember from one of your previous award ceremony or presentation associated with was the idea of a solar-powered health booth. That's the only way I can describe it. Do you think that's got an important role to play in helping with the equitable healthcare?
Yes, it has, because now previously in areas where electricity is an issue and they have to use generator, I mean, we can go on and on about cost in Africa. Everything except the air we breathe comes with cost. We have the generator, we have the issue with the environment, we have the problem with cost with powering the generator. So now having the solar energy, cuts that cost, and they are now beginning to reinvest that cost into bringing the cost down for the people and also installing, more examination kiosks and consultation kiosks across the nation. Okay, can I take that now?
Okay, we'll come back to that one. We'll come back to that one later on, Mary, because I want to move on now to the next question, and I go back to Douglas. Douglas, primary care and the use of telemedicine in primary care. What do you see as the best kind of approach if you're going to use telemedicine and telehealth in that first contact? What's the role of technology in that? We see the 111 services where people go to an operator and the operator go through a series of structured questions. Is that working, or what kind of alternatives do we have to that?
It's a great question, David, and I think we all can relate to the emotional trauma, should I say, in trying to get access to your GP first thing in the morning, going through that whole process of calling up 5 minutes to the hour, only to realize you're 60-something in the queue, and how that feels. And I'll give you an example. As a mental health nurse, I can tell you that when people who are going through mental health challenges, depression, anxiety, need access to services, that whole process is just amplified even more. So the question is this: is there a better way for citizens to engage with the health service? I say there is. There should be choice. Where you can have access to systems that enable you to go through a triaging process before you even appear in an A&E department. These things are surely the way forward. Why do you have to wait to appear in an A&E department before the whole process starts? When you know how you're feeling, there are things that we can extrapolate from you that will enable you to be triaged smoothly throughout the whole hospitalization process. So I think, particularly from a mental health point of view, there is a big role for telehealth to be used not only to stem the flow of patients going into hospital and signposting people to alternative ways of receiving care, because sometimes they don't even need to go into hospital. So this allows hospitals to work more effectively, and also it liberates the individual because they have a better outcome. Because just by going into hospital, you introduce yourself to more risks anyway. So telehealth definitely, I think, needs to be rebooted and amplified in terms of its reach, making sure people have access to the right digital tools, so there's less health disparity, so people can connect to the service remotely on their own terms, face-to-face, where they feel they can have the face-to-face consultation. And I'm a firm believer, yes, that the physical contact is so important. However, if you take a look at all other industries outside of health, from retail to aviation to all these other industries, we're seeing a lot of these things moving towards empowering the individual, the citizen, to take greater control of whatever it is they want to do. So you can book your flight all from, without seeing an operative in an airport or in a precinct. You can do that all remotely. You can do your banking all remotely. Traditionally, you used to queue, and some people wanted to queue. There was a process, highlight some people's day to be in a queue, see a bank teller, and make a transaction. But they had to go through that learning curve with the benefits being clearly articulated. Now, a lot of people now can do that all remotely, enabling them to get on and do more appropriate things and more effective things. And also, we got to understand that not everybody is able to be visiting an A&E department. You've got people that have disabilities, that whole process is very traumatic for them. So we have to be offering choice with an equitable underpinning, so everybody has access, the same level of access to be able to choose what type of way they engage with the health service.
Yeah, I agree with you. I agree with you entirely, and I know that the different routes work for different people, and certainly I would not be keen to go to A&E in any hospital that I've visited recently if I could possibly avoid it. But of course, for some people, they won't have access to the technology. Thanks for that, Douglas. I'll move on to the next thought, which I'm going to bring Leon in now. Leon, in the absence of Noah O'Kelly from Spirit Healthcare, who one of their specialities are the virtual wards, I know you've got a lot of experiences of use of wearable devices and medical grade wearable devices. So what are we seeing with telemedicine in remote care? You know, how do these technologies help for people to be having hospital grade treatment, but within their own homes? Leon, you're muted. You need to unmute your microphone.
Sorry about it. So I would like to start, very interesting question, thank you very much. And I would like to start from some basic information about what wearable does and why actually we need it. And Douglas said that it's very good, empowering, so people should be empowered to control their behavior. And this is what wearables is all about. Because, Douglas, just correct me if my number is wrong, each one generates about 1.7 megabyte of information daily. And this information is transformed into the energy that is directed into our universe. And each one generates, it's not energy that generated in all directions randomly. It's directed to specific thing where this person belongs to. So, for example, it could be some association, it could be workplace, and for patients, it's everything that belongs to patient behavior and patient environment. So, using wearables, we can catch up with this information and use this information for a good for this patient and for a good for all patients' population. So, wearables, they exist for a long time, many years ago. We can talk about ECG monitor, Holter. It's also wearable, not comfortable, but wearable. And just recently, a wearable started like a consumer device. It's not medical grade, it's consumer device. And because we didn't have any other choice, we started to use consumer device like medical device, and some line between medical device and consumer device just disappeared. And what happened that consumer devices just moved all medical wearable devices into very specific niche where patient is a high-risk patient and his condition changes very randomly and very fast. And in this case, we need continuous monitoring of this patient. But there is another thing that deteriorates the problem, that all these biomarkers that wearable could generate, before we generated this exactly the same biomarkers in clinical and hospital environment. It's blood oxygen saturation, the blood pressure, and all this stuff. I'm talking about continuous generation of these. And now we talk about generation of the same biomarkers and same information in home environment. That has a huge impact on context of measurements and context of interest at all. So we have to qualify this wearable on the subject if it really represent endpoint and could be used for clinical outcome assessment for very specific endpoint. And here we could to dive even deeper, because we are not talking today about only one vital sign, blood pressure, or blood oxygen saturation. That is really represent endpoint, but we have much better situation from one point of view, that we have some number of parameters at the same time taken synchronously and in parallel. So what does it mean? It means for these patients, when we generate these parameters at the same time, we can build some correlation between these parameters, and we can build new indexes that better represent endpoint and could be better used in patient assessment. And this is very well started in pharma business, and pharma start to use such indexes to generate specific endpoint and specific assessment. But again, it requires a lot of validation. So all such devices and products, and by the way, wearable device that is dedicated for continuous monitoring cannot survive without platform around it that take this data, collect this data, and maybe artificial intelligence tools applied to generate prediction on the next stage of disease of this patient or avoid any complication. But in any case, to qualify such wearable devices, to qualify this data, it should be initial verification, it should be clinical validation, and analytical clinical validation. So all these three stages should be implemented to qualify such medical device, platform, and indexes and AI algorithm applied to this. Only in this case, this wearable platform could be considered like outcome assessment for the specific endpoint.
So, yeah, so what I'm taking from what you're saying is that if you've got somebody who has a chronic condition and they would normally be in a hospital ward, today they can be cared for at home, but they have to have the right kind of technology to be able to continuously monitor them and the right kind of platform or background to be able to analyze that data and predict outcomes. Yeah?
Yes,
Yeah.
sure.
Okay. Can I move on now to Mary, because this is, in my mind, this is a kind of logical segue to that, and that's to do with preventative healthcare. As you know, Mary, that I'm a great fan of wearables. I've been using wearables for 7 or 8 years, and I have seen how they're beginning to evolve towards more medical grade devices. They're getting more and more accurate with there. But for me, the important factor in the wearables and the mobile devices was that they helped me with preventative healthcare. They give me some indication of trends. They might not be 100% accurate, but they can give me some indication of trends. So if I can see something getting worse, it alerts me, and so it's good for preventative healthcare. So can you say a little bit about telemedicine, telehealth technology for preventative healthcare in your experience?
Yeah, like I said, they're a great thing to have, and they've helped a lot of people, including myself. I had one recently, and it's like told me what I know already, but it was an eye-opener as well. The issue now is, how can we get it across? How can we get people to trust in them? Because up until now, like you said, and like Douglas said as well, they've had the trust in going to somebody, even though they pay for the services, going to somebody to say, bring your arm, for instance, let's check your blood pressure. And they're sitting in front of this person. They know that, they know what they are talking about most of the time. Now we are saying to them, strap this to your wrist or put this on your, inside your thigh or whatever. And it will tell you maybe every hour or whenever you check how you're doing. It's right now, it's a struggle. So you have to build the trust so that we can have enough people buy into it. And then we need the education and awareness as well. And I think that answers one of the question that was asked earlier. We need education and awareness so that people will know that these products, they are able to do what they are designed to do. And the interpretation will help to prevent, like I mentioned diabetes earlier. If we have something that monitors the blood sugar, you can tell the diabetic that, look, your sugar is high, it's low, do this, do that, and then prevent all the complications. Or like, okay, you haven't taken your tablets today, you need to take your tablet, or you've taken too much or too little. But the problem of is the fact that there's not enough to go around, the cost is high, and not many people actually, in my opinion, that need them have access to them. A lot of people in Africa wear them as a fashion statement rather than what they're supposed to do, because that, whatever percentage can afford them, but is yet to reach those people who actually need them. So again, there needs to be rebranding, and there needs to be remodeling as well, so that it will be attractive to users as well as the cost.
Yeah, you make some very good points there. I think the one thing I would say about what's happening with wearable devices, more and more devices are coming onto the market, and because they are being consumerized, the price is going down all the time.
Yeah.
So the accuracy of what they measure is going up, and the price is coming down. So hopefully a lot of these problems will be addressed in the future. Thanks for that, Mary. I'm now going to go on to talk about business models. And for this, I'm going to bring in Brian, because Brian has a bit of expertise in the business models. And it seems to me that the USA, with your medical insurance and how you reimburse providers, the effect of telemedicine and telehealth, who is going to pay for these services, and how are they going to be commercially sustainable? Can you say something about the business models behind all of these?
Absolutely. Great question. It's definitely an area that's really fascinated me from the start. I think, I'm not sure about, I'd love to hear from the other panelists, but, often when you're talking to consumers, before COVID, I would tell people I'm in telehealth, work with telehealth, and they wouldn't even, a large percentage wouldn't even know what that was. Now, people are more aware of telehealth, but it's usually, they only think of direct to consumer, I call it, which I would say is one of the most popular business models, which is just the, provider connecting directly to the patient, webcam, laptop, computer, or phone. But that's just one business model. I think when you look across the industry, and I published a paper right before COVID on telehealth financial variables and business models present in the marketplace, and really came down to, I would say, 8 popular business models. One, of course, is direct to consumer. There's organization to organization, which I think, that's actually where I worked the most heavily at the start of my career in the 2006, 2008, 2009, 2010 timeframe, where we were doing a lot of telestroke, we were doing a lot of telepsychiatry, and we were doing a lot of EICU. And that was all, organization to organization for the most part, connecting. Other models that you see are clinician to clinician. I think that we've seen this has been around for a while with kind of second opinion services, but I think one thing, or portals, I'll say, but the provider to provider, clinician to clinician, I think there's a lot of opportunity there, because you can do things that are more asynchronous or store and forward, so it's kind of on each provider's own time. So I think we'll see a lot of provider to provider models start to come out, across the industry, across the world. And this is a great way to kind of demonstrate more mentoring, teaching, tapping into experts and specialists, especially those super subspecialists like in cancer and oncology. I think we'll see a lot more provider to provider work. I'm doing some research right now in that area. Other business models, mHealth, apps, hardware, software. I'm not going to go through all 8 of them, but those international is its own kind of telehealth business model. Tapping into lower cost markets for different specialists, or just using the time zones to an organization's advantage of kind of staffing through the night, for example. You see that both in EICU and telepsychiatry, telehospitalist program with the nighttime coverage. You see that a lot. And then I often, in the paper, I also kind of break down, 7 attributes of successful telehealth business models. And that's where we, talk about them being safe, appropriate for the patient, patient-centered, user-friendly, compliant, and mission-oriented or strategically aligned to the organization's purpose, mission, vision, and then just valuable to the patient. So yeah, I love talking business models. I'll kind of pause there, and love to answer any questions related to it. But I think it's an emerging area, and when you see the digital health market really growing, we work with healthcare organizations. I also work with startups. I really try to define for them, what is your business model, and are you okay with that business model? Is it sustainable? But I think that, as health systems organizations are really thinking about telehealth, that it needs to make sense from a business model perspective.
Okay, I'm going to bring all of our participants onto the stream now, just to talk maybe a little bit further about the business models. We are used to, in the UK, to have healthcare provided free at the point of service. If a lot of these solutions, telehealth solutions, are taking the load off the health service, of the NHS, shall we say, where does the money come from to cover payment for these kind of things? Who is actually going to pay at the end of the day? Because at the moment, the taxpayer pays for national insurance, for access to NHS services. How's that going to work in the future? And how are we going to finance our health services in a sustainable way, and at least provide income earning opportunities for those who actually take some of the pressure off the NHS? Douglas, did you want to come in on that one?
Thank you very much. I've got a bit of a futuristic way of looking at this. If you go back 15 years in the NHS, we were trying to introduce something called care packages, whereby a citizen could pick, like a shopping list, what sort of care interventions they wanted. And that kind of died. Then obviously we've had other challenges in that time. But I think there's a re-emergence of that type of thinking. If we're saying we can prevent a lot of illnesses and empower the patients at the point of care, which is their home, which is not the hospital, which is their home. We've got to also look at devices and companies that support these devices. For example, if we're saying, don't come to hospital, be at home, effectively your home now is a hospital. Yeah. So governments might need to leverage or make access monies for citizens so that they can make a room in their house a clinically sterile room. Okay. Just thinking out loud. Your vehicle now should be able to be your ambulance. You don't need to be calling somebody. You're talking about with technology now. So automobile industry has a lot to do with being able to surface data concerning to your vital signs. What is it doing at that point of care? So I think with care packages, taking a look at who is benefiting from this data. For example, the data that we collect at the moment, we've got a big challenge of interoperability. So we've got data held on smart devices all over the body, all that kind of stuff. If that doesn't feed into a command and control center to allow healthcare professionals to make informed insights so they can intervene quickly, right? We have a challenge. So just assuming that you are providing data, and that data is enabling research to be done for a particular illness, such as our disease, such as cancer, whatever the case may be. Yeah, you need to, with blockchain technology, you should be able to monetize that yourself. So there's an element whereby the citizens should be able to make money, make make back a return on giving access to their data that will enable companies to make bigger profits for themselves and also sustain themselves. So I think it's a conversation that is at parliamentary level, certainly higher than my pay grade. But as a futurist, I'm seeing technology slowly encroaching in every facet of our life. So if that's the case, we've got to redefine what do we mean by health. Is it more care? As a clinician, I will tell you that a lot of the determinants of health have nothing to do with health. I've seen young people that if you change their school environment, if you provide a better accommodation for them, they will not have depression. Okay, so some of the determinants of what we perceive now as health have nothing to do with health. You've got to look at the whole panacea of well-being. So in terms of healthcare, we're talking about what's the word to say? A care model that supports wellness opposed to sick care.
Yeah.
Only then can we start playing around and with new ways of taxing, new ways of generating income for some of these services.
Well, yeah, that's a very, very good answer. I know I thought some years ago, maybe the answer is to have a kind of citizen social contract with society, whereby you say, look, I am willing to share my healthcare data for the benefit of society, and in some way get some sort of benefit for it. I don't think these things should be compulsory, but I think people should be rewarded for being willing to share their data. And I think that the challenge is how to recognize people who do make a positive contribution to their own healthcare, who adopt good personal health management practices themselves, but also are willing to share their data. Obviously, you have to have protection for people, so the data has to be kept private, and they shouldn't be discriminated against. I think that's the biggest challenge. And I often thought there's a comparison here between universal basic income and universal basic healthcare. Maybe one of the answers is that whenever you are born, everyone who's born on this planet is entitled to free universal basic healthcare. Whatever their DNA structure, whatever their propensity for illness, everyone starts on the same level, and then finds ways of rewarding for people who are willing to contribute their data. I know insurance companies are encouraging people to adopt wearable devices, and I think this idea of a technology-enabled ecosystem is something that needs further exploring. We have one other question here that's come up from Kevin about 5G rollout. Are there any examples of good practice where 5G has come into play and it's being used well? I'd like to combine this question with a final question to all the panelists, and that is, what are we looking at in the future? What's the role of artificial intelligence, and how can we provide equitable healthcare with a human touch? So I'm gonna go round. Mary, can I ask you have you got any good examples of 5G rollout? Is this something that's relevant in Africa?
Yeah, it is relevant. And again, it was scary at the beginning when, this started. Everybody was saying, we don't want it near us. We don't want anything to do with it. But eventually, in some areas where they have it, we were able to dispel the myth, and eventually in the areas where they have it, is working well. In some areas, there's still resistance. And it's only the positive outcome from the areas that have embraced it that we encourage others. And the future and the business model that we've seen have been in the area of the universal healthcare coverage that the government across the LMIC are trying to achieve, and the NHIS, which is another story for another day. But, but we have the public-private partnership, which initially people were focusing on government, but now they've come down a notch. They're beginning to work with independent hospitals, in private institutions, and schools. One of our partners is working with an hospital that specializes in pediatric to do wellness. So schools can come there and they can teach the children about telehealth, telemedicine. Again, they go home, they tell their parents. That's another way of increasing adoption. And the other side to that is we need to do what they did in fintech. Look at how fintech is in Africa. I think we are leading, actually. They went to the market women. The other day, I was excited about train station. I went there to go on the train. People were lying there. Oh, did you leave your money at home or your card at home? You can get money here and buy your ticket. We need to get telehealth to that level. Then we'll increase adoption. Then the other business models, like the diagnosis for cancer, other business models will thrive through a lot of NGOs are doing a lot, but they are all looking towards government, and that is being disseminated now, which I think will increase adoption, will increase accessibility and equity as well.
Okay, thanks for that, Mary. Douglas, I know you've got a hard stop at 3 o'clock. Do you want to say something quickly about AI? Is there a bright future for AI in healthcare?
I think there's a role for AI, most definitely. I think as a guide, as a guided device or program, whatever way it manifests, to provide actionable insights. And I think there's a lot of re-education that we need to do in terms of artificial intelligence. There's too many sci-fi films populated from the 80s, 90s, 2000s that scare a lot of people when it comes to this technology. But essentially, if it's able to crunch, harvest, cultivate data and surface that to the individual to say, look, if you make this decision, you're going to increase your likelihood of being able to live better, that surely has to be applauded and encouraged. What we do with the data needs to be more open, transparent as well, and people need to be held to account when they misuse citizen data.
Absolutely,
that's what needs to happen. We see a lot of just verbal spanking of big companies that have misused citizen data, and that doesn't bode well for enabling other people to want to embrace that technology. But yeah, I'm a big believer in using technology to enable us to do the things that we want to do with our lives, because a lot of us are involved in activities, let's be honest, that are repetitive, that do not allow us to bring our full creativity to bear. So yeah, I'm a big fan.
Good. Leon, artificial intelligence, AI. What's your view on that?
Yeah, basically, any intelligence is based on capabilities to generate, collect, and process the big data. And they were talking about 5G, or we're talking about all this stuff, how we generate data. Trend is clear. So when we will have so much data that will enable to build our artificial neuron systems, we'll be able to process this data. We will be able immediately react on any changes, and we will be able, using some learning capabilities, to predict what happens in the nearest future. So this is the trend. And what we have to do today is to work on the strategy. And strategy is a set of specific choices how to reach some fixed point. And we have to understand what is the fixed point in the year or in the 5 years, and build a strategy using all these environments: data, capabilities to accept, processing capabilities, people's behavior, all these around, to build and to come to this fixed point. I am basically professionally, I'm quantum mechaniker, quantum physicist, and know how quantum physics just works. So when you fix something in 5 years, it exists already, because all capabilities exist in superposition state. So you fix it in your mind, you materialize it now, and you know exactly how to reach there. And this is what we have to work on today. And this is what Occiton is doing today.
Good. Thank you, Leon. We've had to say goodbye, unfortunately, to Douglas. And we're very close. Well, we've actually slightly run over. But Brian, I'll give you a chance to just say very quickly your views on the future of AI.
Yeah, I agree with everybody. I really like the way Leon put it as well. And it's been so fun being on this panel with everyone. I could talk all day with you guys. You know, AI, I think, especially in telemedicine, telehealth, I think I heard somebody say one time, and I can't remember who said it, but that we have a lot of A, but not enough I. And I think that over the next 5 years, 6 years, if we can move more to the intelligent side and kind of more insights from that data, more actionable insights, you know, that actually kind of pump into these, you know, care models in kind of efficient ways that makes it, you know, you can kind of have broader scale population health, you know, health of a population, et cetera. I think we'll do a lot. I think what I'd like to see over the next few years is more legislative action, policy action to kind of put some of these things in place, especially for these maybe different to really address equitable care. I think you can really target, you know, different parts of the country, different populations, and really razor in on, you know, some of those health disparities that are affecting different populations differently. And it's all across the country and all across the globe. So I think we'll start to see more organized legislative and policy efforts to address that and address it with technology. So it's been a pleasure to be here. Thank you. Okay,
thanks very much for that, Brian. Thanks to Leon and Mary, and also to Douglas. Now we're gone. I'm going to bring the session to a close, but I just the last question from Rosa. She arrived late. Can I revisit the recorded meeting? Yes. The meeting will be published on YouTube, and I'll find a way of getting you access to that. Probably publish it on LinkedIn with a link to the YouTube situation. So thank you to my great panelists for joining me this afternoon, and thank you to those of you who were with us for the whole session, and I hope you really found it worthwhile. Thank you.